Hello friends, back with another session here. Here we'll discuss some few points regarding cardiovascular changes during pregnancy. So let's start it. There are some factors which increase during pregnancy and some factors which decrease during pregnancy, and these are normal changes to occur. Now, the factors which increase are first of all the cardiac output. Cardiac output is increased during pregnancy as the cardiac output is product of stroke volume into heart rate, and in pregnancy the stroke volume increases and a heart rate also increases. Ultimately the cardiac output will increase. The more is the increase in the cardiac output, the more are the chances of heart failure. So as the cardiac output increase, there will be chances of heart failure. The female will be more prone for heart failure at that time when she is having a higher cardiac output. So overall, maximum cardiac output you will get in the immediate postpartum period. Okay. So the maximum cardiac output you will get in the immediate postpartum period. Okay. Immediately after delivery, you will get a higher cardiac output, and it is a 70% of all the increased cardiac output. Um, and in the second stage of labor, and then in the late first stage of labor, and then during pregnancy, it is in the 28 to 32 weeks of pregnancy. So this is the it is in descending order. The highest cardiac output you will get at the immediate postpartum period, then second stage of labor, then the late first stage of labor, and 28 to 32 weeks of pregnancy. It's very easy to learn also that just after delivery and before delivery, when the female is in second stage of labor, and before that in the late first stage of labor, and before that 28 to 32 weeks of pregnancy. And when cardiac output is more, the chances of heart failure is also more. So just remember this point, chances of heart failure is more at that time. Okay, now the second point, stroke volume increases, heart rate increases. As heart rate increases, the pulse rate also increases in that pregnant female. Femoral venous pressure is increased during pregnancy. Normally it is 8 mmHg, and during pregnancy it is increased to 20 mmHg. It increased due to pulling of blood in the lower limbs because of the gravid uterus pressure over IVC, because in the pregnancy the uterus is retroverted, and normally the uterus is anteverted and anteflexed, but during pregnancy it is retroverted, which will gives a pressure over IVC, inferior vena cava, and leads to pulling of blood in the lower limbs, and thus the femoral venous pressure increase, and the oxygen consumption is increased during pregnancy. Learn this fact also. Now the next point, factors which decreased. So vascular pulmonary vascular resistance. Pulmonary vascular resistance decreased during pregnancy, and because of, and also peripheral vascular resistance decrease. So peripheral vascular resistance, you can also learn pulmonary vascular resistance, both are decreased during pregnancy, because during pregnancy the main hormone is progesterone, and this progesterone is a smooth muscle relaxant which relaxes the blood vessel, thus the vascular resistance decreases, and the blood pressure also decreases during pregnancy, and there is more decrease in the diastolic blood pressure more than the systolic blood pressure, and the maximum decrease in the BP is seen in the diastolic blood pressure, and a maximum in supine position, and in maximum in second trimester. So in diastolic blood pressure, supine position, okay, and in the second trimester there is maximum decrease in BP. Okay, so these are 3 points which you have to learn because these points can be asked in a question, that the maximum decrease in BP can be seen in three factors, in three points. Like in the diastolic blood pressure, you will see more decrease in BP than systolic blood pressure. In supine position, you will see more decrease in the blood pressure, and in the second trimester you will observe the more decrease in BP. So BP is generally decreased. Systolic, either diastolic or the mean arterial pressure, all will decrease during pregnancy. And I have missed one point, the femoral venous pressure increased. That means there is pulling of blood in the lower limbs, which will lead to three things: edema, varicose veins, this is pedal edema. So pedal edema, varicose veins, and hemorrhoids. So it can lead to these three things. Just advise the female to take a bed rest. Okay. And the AV oxygen gradient is decreased during pregnancy. It is decreased during pregnancy. While oxygen consumption increases during pregnancy, and AV oxygen gradient will decrease during pregnancy. And a supine hypotension syndrome. This is a very important syndrome, asked multiple times in the exams, and also important from day-to-day perspective also, because a female sometimes goes into this condition of hypotension. It occurs in late third trimester, when the gravid uterus pressure on the inferior vena cava, at that time the uterus is at its higher level, so there is more respiratory discomfort to the female, and also the pressure is more on the inferior vena cava, leads to decreased venous return and decreased cardiac output. Okay, and this decrease in the mother will leads to hypotension. In the mother will lead to hypotension. Her BP will decrease more, and in the fetus it will lead to fetal distress. Fetal distress because of all this. So in the mother there will be hypotension, there will be tachycardia, because as BP decreases, okay, as BP decreases the pulse rate increases, and also syncope. The syncope can be there. And in the fetus there will be decreased fetal blood flow leading to fetal distress. Thus the patient is advised to take rest in the left lateral position, advised to left lateral position, and BP is quickly restored in that. So the crux of all I have told here is, during pregnancy, in the late third trimester, okay, when the female lies in supine position, the gravid uterus gives pressures on inferior vena cava, which will lead to decreased venous return and decreased cardiac output, and ultimately there is decreased blood flow towards the fetus, and leading to the fetal distress. And in the mother, as cardiac output is decreased, venous return decrease, cardiac output decrease, it will lead to hypotension in the mother, and also tachycardia. Okay, and tachycardia. So thus advise the female to advise her to lie in left lateral position. Advise her to lie in the left lateral position. This is the best position which can immediately provides a relief to a female. Okay, and the BP is quickly restored in this position. And this when the gravid uterus pressures on IVC, there are some collaterals which open. 90% of the collaterals open during that time, which are azygous vein and paravertebral veins, but the 10% collateral fail to open. Okay, now the next point, the regional distribution of blood flow. So the pulmonary blood flow increases and the renal blood flow increases, uterine blood flow increases 50 ml per minute in non-pregnant female and 70 ml per minute near term. So pulmonary blood flow increases. Also, renal blood flow increase, uterine blood flow increase, and the blood flow towards the skin and the mucous membrane also increase, which will lead to heat sensation and stuffy nose and the sweating. So this heat sensation, sweating, and stuffy nose during pregnancy is due to the increased blood flow towards the skin and mucous membrane. Now, the normal changes in pregnancy, and these are important to remember so that you can differentiate what are normal and what are abnormal in the pregnancy. So, the heart rate increase leads to increase in the pulse rate. The BP decrease, the more is a decrease in the diastolic blood pressure in supine position and in the second trimester, and the heart rotate upwards and outwards. As the heart rotate upwards and outwards, it pushes as the gravity uterus pushes diaphragm and diaphragm pushes heart. So for that will lead to upwards and outward rotation of heart, which will lead to palpitations and ECG changes, apex beat position shifts. So the ECG, in the ECG you will see left axis deviation. In the chest x-ray, you will observe mild cardiomegaly. In the chest x-ray, you will observe mild cardiomegaly, and the apex beat position is shifted. Where? So the apex beat position is heard in the fourth intercostal space in 2.5 centimeter lateral to the midclavicular line. See, this is a normal thing. In the fifth intercostal space, this normally you can hear the apex beat position in the fifth intercostal space in the midclavicular line. Let's suppose this is a midclavicular line. So 1.25 centimeter medial to the midclavicular line, you can normally hear the apex beat. But during pregnancy, as the heart rotate upward and outward, you will heard that you will heard this apex beat in the fourth intercostal space, not in the fifth, in fourth intercostal space, and 2.5 centimeter lateral to the midclavicular line. Now coming to the heart sounds. So what about the heart sounds? Heart sounds, okay. Normally in the normally we will listen that S1, and we can also listen that we can also observe S1 and S2 only, but during pregnancy the S1, S2, and S3 is also easily heard during pregnancy. In the S1, S1 will be loud, and there will be a wide splitting or a prominent split, loud and a wide splitting of S1 due to early closure of the mitral valve. So due to early closure of the mitral valve, there is a wide splitting. And the S2 is normal in the pregnancy. It is normal in pregnancy. S1 is loud and wide split. S2 is normal, while S3 is easily heard during pregnancy. Now coming to the murmurs. So in majorly the systolic murmur, ejection systolic murmur is seen due to decreased blood viscosity and torsion of the great vessels. So due to decreased blood viscosity and torsion of great vessels, the ejection systolic murmur is normally seen and intensified at the time of inspiration, and normally seen normally you can hear with stealth. And this in 20% cases a soft diastolic murmur is observed, and in the 10% continuous hissing murmur over tricuspid area in the second and third intercostal space. So in the second and third intercostal space over the tricuspid area, you will get that continuous hissing murmur. It is also known as a memory murmur, okay. And now what are the things which is remain unaffected in pregnancy? It is JVP, jugular venous pressure, central venous pressure, and ejection fraction. It is normally remains unaffected during pregnancy, okay. So the next point, normal changes which mimics heart diseases. So these are the normal changes which mimics heart diseases. These are hyperdynamic circulation during pregnancy, the systolic ejection murmur, dyspnea, exercise intolerance, fatigue, syncope, tachycardia, shift of ventricular apex, loud S1 with splitting, and a memory shuffle. So, the careful investigations are to be done to confirm these diagnoses and differentiate them from the abnormal things. So, just remember all this: the hypodynamic circulation, or the systolic ejection murmur, or the loud S1 with splitting, tachycardia, shift of ventricular apex, exercise intolerance, dyspnea, fatigue and syncope, and a memory shuffle. These are the normal changes, okay? Now, the next thing, thank you so much for watching this video. Stay tuned for more upcoming videos.